Hello, my name is Kevin Gibbons, and I'm going to give a presentation on the process mapping section of our baseline assessment of emergency medical transportation services synthesis report that is for Clinton Health Access Initiative in Uganda. Just to give a brief overview of the assessment, I'm going to start with baseline assessment, talk a little bit about process mapping, the methods that we use to do this participatory process mapping, and then some key terms that I've mentioned just in case you're new to Uganda. The EMT baseline assessment was conducted as a research baseline in the districts of Kagadi, Kakumiro, Kasanda, Chibale, Mitiana, and Mubende in Uganda. Our goal was to understand how people access transportation in both community to facility transportation needs and referral emergencies. And then after that, as doing that research, we identify gaps and make recommendations. So as one big part of that, we did focus group discussions. And a major part of the focus group discussions was to do process mapping. And process mapping is often used in business and IT. You start with a question, and then your goal, for instance, when there's an insurance claim filed, how is that processed in our organization? When a user to a website submits a form, how is that name recorded and then put into the database? In our case, the questions are, when a person identifies an emergency, what process does that person undertake to then reach the health facility? And so that's an example. And so the goals of this process mapping are to document this process using the people who are most involved in it, to then visualize it so that the group comes to an agreement and it can be shown to others, and then use this visualization to identify gaps and inefficiencies. And in our case, it's also all of that is also to foster discussion among the populations that we were doing focus group discussions with. The major components that are most commonly used in process mapping are processes, breaking it down to the actions or processes individually that are done, decisions, which are usually questions where a process will branch, the way a decision tree might branch. Do you choose to take a taxi or do you choose to walk? And then what process happens based on that? And then you have inputs and outputs. That could be in the form of a form, a email, a notification to your phone, and then lastly, data storage. Once those input and outputs are generated, then how are they saved so that they can be analyzed later on? Here are some examples. For example, pay at the pump. When you go and pay in the US and you pay by yourself and you scan your credit card, what happens? You first swipe your card, then the card is authorized. If it is authorized, then that data is stored. You select the fuel grade, and then you have to have the process, is the fuel grade remaining? If not, you have to get an error message and then have the person go, then select another fuel grade. After that, you pump gas, finalize the transaction. Once that's done, then the transaction data is stored in the system. Then it asks you if you want a receipt, and if you do, it prints your receipt and you're done. And if the card is not authorized, you get an error message and then you're done. As you see in this process map, you always have a start in the top left, usually in the top left, and then you have an endpoint in the bottom right. Another example of a process map here, to process an insurance claim. I just want to note the parts where it splits. Does the person have valid insurance? That check is made, and if not, that claim is rejected. What is the severity of the claim? And then that entails different processes. This decision part is an important part where if something is quite different, then that splits. And then lastly, the one we said of making matoke, which are boiled plantains, a common staple food in Uganda. And in this example, you see how there are swim lanes that are designated to, and they're colored to designate roles involved. You have the chef, the assistant, and the diners. The diners would choose the type of boiled plantains that they would like, and depending on the type that they would like, that leads to a different process to prepare that matoke, serve it, eat it, record feedback. Doing this practice with our group, you realize how important it is to understand the roles, and that was very true of the process maps that we ended up making to try to identify what does the health worker do, what does the driver or transporter do, what do those things entail. Next, the methods that we used. This was a participatory process mapping, so we'd have usually the focus group discussions would be around 6 participants, usually between 4 to 6 participants, and then those participants would answer the two questions, which, either of the two questions. One, how does a patient go from, once an emergency is identified, go from the community to the facility if they need an emergency transportation, or otherwise, once an emergency is identified at a lower level health facility, how is that patient transported to a higher level facility? So it starts when an emergency is identified, and it ends once the patient is delivered and treated at the next facility. We use this to identify those gaps and opportunities, which some of which we'll list out in this presentation. And then the analysis, was to analyze the text of those gaps and opportunities that were listed out by the participants. Also to analyze visually the process maps that were generated, and then create composite process maps. So you see, we would start with this process where you have a facilitator who is then meeting with the group. At the end, you would have something akin to this presentation right here. And you'll notice that these are using sticky notes, in which the yellow are processes, the greens are decisions, the blues are input outputs, and then the reds would be data storage, though none were recorded here. So then from that, we made composite. We analyzed those in the in vivo data qualitative analysis software, and then created composite maps like this one, which we're going to review in more detail. So we started with that group, with that issue with the post-its, and then took the most salient parts in the two different types of maps and created these composite maps, which I'll run through next. Some key terms that I will be using a lot. One are village health teams, or VHTs, and those are community health workers in Uganda. Boda bodas are motorcycle taxis, or motorcycle taxi drivers. Special hires are private hire, cars. And then we'll be using IDI, came up a lot, and IDI was an implementer of this of the Saving Mothers Giving Life program in 3 of the districts that we worked in, and they factored in a big part. And so let's start with the community to facility process map. I'm first going to give a tour of the process map, and then I'll outline some of the major gaps and opportunities that we gained from this exercise. Starting with this process map, you see we start here at the identifying the emergency. I want to point out that we'll be using an additional symbol, this symbol for a document, because most of all of the forms or data that were processed in were done through forms rather than using a computer. And the roles here are split by colors. So red is the patient and caretaker. The blue is the referral facility where the patient is going. The purple is the VHT, and then the green is the transporter. So you'll notice that this is a very, the VHT and all the purple is quite involved. And one reason for that is that we were doing these focus group discussions with VHTs. So the role of the VHT in some cases was exaggerated, but was certainly laid out very clearly because we were meeting with VHTs. Whereas you'll find that VHTs in some of the emergencies we heard of were barely involved or not involved. So the VHT would first give, basic first aid, and this was very rare, but the VHT could fill a basic referral form, identifying the condition, what the recommended treatment was based on the minimal training that the VHT had, and then that copy, a carbon copy of that, would be stored at the VHT's home. Next, they would figure out which form of transportation would they use. In most community to facility emergencies, an ambulance was not an option. An ambulance in the places where we visited was almost solely used for referral transportation from a lower level to a higher level facility. But so in this, the process for using a boda or a special hire was pretty much the same. If the person had money available, they would see if the vehicle they needed was available. If not, they would need to get a loan or a collection from friends and family. And then sometimes this was quite a delay, and this took a bit of time. Then they say, is the vehicle available? In some remote areas, you might not be able to get a boda or a special hire, so somebody would have to take a bicycle or walk to the nearest stage. And then from there, you could call the transporter. Really, the vast majority of cases used a boda. Then you would call the transporter, the vehicle would arrive, and then there would be a bargaining process, which could really delay things. And there could be, we'll talk about the gaps later on. There could be overcharging based on the emergency or time of day or the weather conditions. If that driver trusts the patient, then he'll go ahead and take that patient and go on to the next step. If not, that person would have to pay a deposit before that transporter would go anywhere. After paying the deposit, if there was a caretaker available, the caretaker would accompany the patient. If not, the VHT would accompany the patient. In the vast majority of time, it would be a caretaker who would go with the patient to the facility. And then once they reach the facility, they would have to search for a health worker. In an ideal world, the patient or the VHT would give the health worker that VHT referral form, so the health worker has some background on the patient. They would then admit the patient. And that's where we thought it would stop, but these following processes were a big part of what they said were involved in emergency transportation. Once the patient reached there, you had to wonder, do they have supplies? In some cases, patients were turned away or just left to sit on a bed because they didn't have to have the supplies there. So they have to go purchase the supplies, maybe call and try to find money to purchase those supplies. Then that patient could be treated at the facility. Ideally, once the patient is treated, the health worker would fill out the VHT referral form, the bottom half of the form to report the outcome, would discharge the patient and give the patient the form and hopefully keep a form in the health facility. Later on, it would be the responsibility of the VHT to visit the health facility to then record that information, remember it, and then write it down on the stored form in the VHT's home. These steps almost never happen from what we were told, but this was the ideal. And if we can back up, in the case of using an ambulance, which was exceedingly rare in community to facility transportation, they said you'd first figure out whether money was available and go through the same process that you would for a private hire, which is to get loans from family and friends. Then you'd be able to call the ambulance if you had enough money for the fuel. The ambulance would not come unless the patient had money for fuel. They would pick up the ambulance, then you would give the money immediately to the ambulance to pay for fuel, and then go through the process just as we went through with the private hire. So that's an overview of how that process goes. And you'll notice that bargaining and getting the money and collecting money takes up a big part of how this process goes, and it also consumes a lot of time from all reports. So now let me talk about some of the major gaps that we found out through doing this process. I'm going to, money, we're going to classify these in money, transport, and social support. Under money, you have the money for transport. And here's a quote. Here in Chivale, there are private ambulances. Ujune, there is a private ambulance. In Inesco, there's an ambulance. But the money needed, the average person can't afford it. We lost a person. She was taken to Mubende. They asked her for 350,000 Ugandan shillings. And yet she didn't even have 100,000 Ugandan shillings. So she ended up dying, and the ambulances were around. They tell you put in fuel. The ambulances use so much fuel. This was the biggest gap that we saw, was that people didn't have enough money to afford the transportation, whether it was an ambulance or a boda or a special hire. That's what people really struggled with. Next is overcharging. Under money, and here's some quotes. The biggest gap in getting the means of transport and bargaining on the amount of money to be given to these bodas. We also have the gap on negotiating how much and on the way of paying these boda men, since some of them see that the other is poor. They ask for an exchange, sex, or property. And we heard this a lot, that people would have to sell their land or sell an acre of maize or exchange sex in some cases to get a ride to the health facility. And even transporters themselves stated and admitted to us that in cases of emergency, they do add an additional charge. And in fairness, this has to do with the increased risk that they take on by transporting an emergency patient. And here's another one. Depends on time. If it is daytime, like it clocks before 7, it is 30,000 Ugandan shillings. The person of a special hire car will come, put you there, and transport you to Kagadi at a fee of 30,000. But if it's at night, that is past 9, it goes up to 50,000. And that's what we heard. At night or during emergencies, people charge 1.5 times to 3 times as much as it would be on a normal time, at a normal time or during normal situations. Lastly, money for supplies. Some mothers don't have the necessary things to use for childbirth, like baby clothes, and even they themselves don't have clean clothes. They can't afford them. So instead of getting embarrassed in the health centers, they prefer traditional birth attendants who don't really care about all that. And that's what we heard, is that patients were intimidated by going to the facilities, health facilities and not having the supplies that would be required of them, namely gloves, bed sheets, and plastic sheets for giving birth. And so they would be sometimes shamed and sometimes not served or turned away if they didn't have those things. So for those reasons and maybe bedside care and quality of services, patients would end up choosing to go to a traditional birth attendant. And lastly, collecting money as a major delay. And here's a story. There was a lady who got sick, and after that, she came here and was treated, referred to go to Mubende Regional Referral Hospital. But the problem was that her family was very poor. Now they started to look for money. Meanwhile, we helped them so as to go to Mubende. During those days, transport means by car wasn't very good. They got a vehicle after 2 days. I also had my money as a VHT and topped on their contribution. On reaching the car driver, the amount he wanted was not the amount we had, so we went back to look for the other money in order to raise the amount the car driver wanted. In the morning, the patient was in a worse condition and eventually died. But she didn't die out of our will, and because of the poverty of her family, they couldn't hire a vehicle. And also, us who had to help had no money, because I had only 30,000 shillings and gave them 25,000 and remained with 5,000 for upkeep. So the patient died, and we buried her in grief. But the whole problem came as a result of not having money for transport and even not having anyone to support us. So you see, in this story, you see that the major delay was finding the money, going through all these different sources to get the money that is required for the transportation. And we heard quite a few stories like this in which people said eventually they would get the money, but the delays would cause so much. You see that maybe they didn't want to travel at night, or it took them the whole night to reach someone to get the money. So the transportation was there. The money might be there, but just getting it in time was a major delay. Another major gap was transport and transportation. There were serious lack of alternatives to bodas. In most places we went, even when we said, well, what about special hires? What about using ambulances? Many of the respondents would laugh at us, say, look, we don't have that here. People can't afford that here. The only thing people can take is a boda and or walk. And so to jump on the back of a boda, no matter what condition the patient is in, that was what was there. And poor roads. This was mentioned in, if not every interview and focus group discussion we conducted, just about everyone. And here's a quote. The problem of roads, as my fellow colleagues have said, is also a big problem. Because you find the roads are impassable, you find the motorcycles and cars can't go there, whereby the mothers end up delivering in the villages all because of bad roads. Even if they plan to deliver at the facility, they end up in the village. This was mentioned to us over and over and over again, that the quality of the roads caused major issues. And then traveling at night. Another issue that brings a challenge within this job is that sometimes you bring a patient here at night, and on checking him or her, the health workers realize that he or she needs a referral when they cannot manage the sickness, whether 11 p.m. or any time. So to connect with transport to come here to take that patient to Mubende Regional Referral Hospital at night becomes a big problem. So even if you have the money, many private hire bodas or special hire drivers will not travel at night because of safety issues on the road, crime in certain unsafe areas. So that was a major inhibitor. And then lastly, a topic I want to touch on, a gap that was mentioned a lot, was lack of social support. And specifically one that came up a lot was male involvement. Two quotes. We had a case where the patient was undergoing treatment. The husband waited for nurses to leave the wards before stealing her and taking her to a traditional birth attendant. To reach there, she became worse, whereby he rushed her to Kagadi Hospital without a referral, and yet she was still undergoing treatment there. And so in this case, the husband or male involved decided that he wanted the woman to go to a traditional birth attendant, so took her out of the health facility. And we heard a lot of cases of this where the man would prefer to go there. And that we heard a lot of other cases in which the man just refused to answer the phone or did not want to be involved in the birth process at all. Here's another quote. The other things that frighten these men from coming with their wives to the health center, they have told them to prepare necessary things for delivery like gloves, kavera, plastic sheets, and some money for emergencies. And that time when the woman has started labor and has come to the hospital and has been transferred, and they're asking for too much money, which the woman can't afford, and the man can't afford that money. So you find that when the time for deliveries come, the husband will hide. So, in essence, out of shame of not being able to provide or give the health workers what they require, you'll find the man just doesn't show up. And so now I want to talk about some of the opportunities, which are VHTs and Good Samaritans. We see a lot of potential in VHTs and how they can help maneuver and navigate in the case of emergencies. Another thing to add on, please, as we VHTs, we have contacts of our doctors at the health center, and we have contacts of all the health workers here at the health center. And at night, if someone calls me saying, I request for your help, I have to be taken to the health center, the first thing I do is to call the doctor or midwife at the hospital, and I inform her that I have someone here with a sickness and I'm bringing her. By the time you reach there, you find the midwife already waiting for you. On going upstairs where they sleep, you find her already dressed. So we attend to the patient. The good thing, we have their contacts, so we call them, and they're approachable. We cooperate with them, and we have no problem with that. So you see, in other cases in that process, it can be difficult to find the health worker, to track somebody down. If you're a patient, you might not know who is on duty, how to reach that person, but the VHTs can help to smooth that process and reduce delays. Another opportunity are Good Samaritans, and here's one example. Sebagala, there's a man who was ever available for cases before the ambulance was there. He could come in, and when the ambulance was done again, he could come. He is the only man whom we approach, and he has never failed us. He's a taxi driver, and he's the one who charges at a fair price. He charges between 60 to 70,000 shillings. And this wasn't all over in all places we met, but there were a few places where somebody would know of a special hire driver or a boda driver who would not overcharge and would help in cases of an emergency. Sometimes it was maybe a public servant, somebody who worked at the district, or just somebody who had a kind heart. And so those people are around and do propose a good opportunity to improve community facility transportation. Okay, so now let me talk about the referral process map. In this one, I'll just give a tour of the process map and then go over some of the gaps. So here is the map, and again, same key, process, decision, input, output, document, and data storage. We have the referring facility where the patient is originating in yellow, and the referral facility where the patient will end up in blue. So we start with identifying the emergency and health workers giving first aid. Ideally, those health workers would explain the condition to the patient and then assess whether a caretaker is available for the transportation. If not, They could contact VHT in the area, who could contact friends and family to get a caretaker to join. Once a caretaker is identified, they'd figure out which form of transportation they wanted to use, they needed to use. So in the case of a boda or a special hire, same as before, you'd call one, then you'd first bargain with the price and see if that money is available. If the money's not available, they would say here collect, which could also be take out a loan. And then at the facility, they said if that money is enough, you'd go on to the next step. But there were many cases where someone was in dire need and they would have to collect contributions at the health facility of health workers, which they found quite difficult, that the expectation would be that they would have to pay for transportation in these emergencies. But assuming that once they get enough money, then they fill the referral form. It's a two-part form, and they would fill the top form out so that they can introduce the patient to the referral facility, and they would keep one copy in their referral book. And depending on the condition, if the woman is pregnant but not delivering, then they would fill out an antenatal care register and retain a copy of that in their register. And if the woman was delivering, then they would fill a maternal register and keep a copy in there. For any other condition, they don't have any other specific forms other than the referral form. So once that is done, ideally you would call the referral center, though we were told that this almost never happens. We'll go into more detail later, but that it was very rare that health workers would call the place where they're referring the patient to tell them ahead of time. Then the transporter would transport the patient. Once they reach there, the patient and caretaker would search for the health worker and hand over the referral form to the health worker, though this often didn't happen. And then they would admit the patient, treat the patient. Once the patient had been treated, fill the second part of the referral form to report the outcome of the emergency, retain a copy for themselves, and send the fully filled form with the patient and discharge the patient. And then the patient would be in charge of returning a copy of that referral form to the referring facility. And then the referring facility would retain a copy in their referral book. But again, we heard that this almost never happened. And just to go back a little bit, in the case of an ambulance, when an ambulance was required, the first step would be to request permission from the admin. And this process varied widely because of the various types of ambulances. There were ambulances that belonged to and administered by the facility. There were some that were owned and operated by a member of parliament. And there were some previously that were administered by IDI. So you'd have to get some kind of request for permission from the administrator, because the driver would not travel unless usually the facility in charge or somebody at the head of the district gave approval to go pick up and deliver the patient. Then and only then would you be able, and this was a significant delay, then and only then would you be able to call the ambulance. The health worker would then check to see if there were supplies in the ambulance for, gloves, kind of just basic medical supplies, and then see whether there's fuel in the ambulance. And almost invariably, the fuel was the responsibility of the patient to pay for. So you'd have to figure out whether that patient had enough money, how they could come up with the money in the same way that you would for the other forms of transportation. And then the rest would go the same. So I want to talk a little bit. So I just want to mention some of the gaps that we found in this process that were different from the community to facility gaps. And these are in admin, transport, and communication. On the admin side, we don't have quotations for these, but the major problem was that there were no clear policies. Each health facility seemed to administer their ambulances differently. There were members of parliament who had ambulances that were fully operated and managed by them and had no oversight by the health facilities. When we would ask, well, how do you request one? They would sort of shrug and say they would call the driver and hope that the driver would pick them up. They didn't have any kind of role of authority over the ambulance. And there were not clear policies on whether a health worker would accompany the patient to help sustain the patient on the trip. There was just at the district and health facility level, we did not find any specific EMT guidelines. We just all we heard were, oh well, this is how we do it here. So there were very sort of ad hoc policies. And this issue of oversight, who's in charge of what, was quite confusing in many different cases. How you would requisition the ambulance, who would be in charge of doing the maintenance. All those things led to sort of confusion in how EMT resources were administered. Lastly, sort of access to transportation. There were few ambulances, and the issue of maintenance was a big salient one, as to what would be expected. As you can see in this map made by Maggie at Clinton Health Access Initiative, there are large gaps where, in the entire district of Chihuahua, large areas of Kagadi, where people do not have almost zero access to ambulance transportation. In the areas where you see a lot of access to transportation, a lot of it comes from these members of parliament, which are most of the green ambulances that are laid out there, and those serve a particular constituency for that person. And then there are a few other ones. So these major gaps meant that in a lot of these health facilities, they don't expect and do not have any access to ambulances. And next, lack of like clear policies for how to maintain vehicle resources that were there. Here's a quote. Previously, we had an ambulance which was stationed in Kagadi some time back, and then we used to have the ambulance telephone numbers that we would always call, hotlines. These people would always pick these mothers from here. It was a good initiative. It was working by then, but issues came whereby I think the ambulance stopped picking people. It also became a little bit tricky when some of the projects had gone down, so that transportation of Kagadi supported us or other facilities, and other people in those villages was halted. So these are examples from IDIs, Saving Mothers, Giving Life, these tricycles and the Land Cruiser ambulance right here. This ambulance had not been working for at least a year since the IDI SMGL project had shut down. So it seemed to be in working condition, but the driver was no longer receiving a salary. Nobody could afford to pay for the fuel and a stipend for the driver. So it was not used, though it was passed off to the district to be used by the district in Kagadi Hospital. And the same with some of these tricycles. It seems that some could be repaired but since they're sort of unusual vehicles, not just any repair shop can do them, and it wasn't clear who owned them. Everybody said they belonged to IDI, so it was unclear how to maintain them. And so maintenance, in a way, of that previous projects had come in, and then as after funding dried out, there wasn't a lot of sustainability. Communication. There were big questions about whom to call. Who do you call for an ambulance? Who do you call when you have an emergency to get access to a special hire or anything? Which bodas can you call? So here's the question. So is a communication problem to connect with the people there? Is that what you mean? And then the respondent says, yes, to connect with the people who are supposed to pick up a patient for a referral. At times you find when the phones are off. At times they tell you they're also away. Now you as a VHT carry that burden, so it becomes a big problem. So these lines of communication really break down, and there aren't, you don't just have one number. You have a particular health worker, you have the number of a transporter or driver, but as you can imagine, those change, and people aren't necessarily available at all hours. And then the last gap that we'll mention here is that there just seems to be no interfacility communication. Health workers do not inform the referral facility that a patient is on the way or what condition they have. A patient is sent with a referral form, which may or may not be delivered, and there just is almost zero communication and coordination between facilities. And so that's the overview of the process maps and gaps and opportunities that we came to through that exercise in community to facility and referral emergency medical transportation. Again, I'm Kevin Gibbons, and thank you.